Let's start with case conceptualization. So the primary goal of case conceptualization is to really have a mechanism that explains a presenting issue, right? And the problems, the presenting symptoms and underlying problems that might be there for a patient or a client. For me, it's only useful if it helps to organize the information of what might be the most relevant places to start and kind of disregard some of the potential irrelevant information, right? It's a heuristic. This is a process of parsimony. And it's one that I don't typically have to write out anymore as I go. I almost, when I'm talking with a family and I'm doing my intake, I start to already plug things in to things that are working for me. I don't think there's any one way to do this, as long as what it does is it's treated flexibly, and it helps you as a place to start with understanding, putting yourself in the client's shoes, and helps you in a sense of not just saying, I'm going to insert CBT here, but how am I going to use this in the best possible way, given the complexity of the case in front of us. Everybody comes with a story, and this is how do we organize that story, right? This is not a bag of tricks. It's not meant to be a bag of tricks. We'll do a little bit more of the strategies tomorrow in terms of different components of CBT. But this is really about understanding the person, and we try to keep it as simple as possible. That being said, I'm going to show you a number of them in your slide handouts. You have a lot of different models that people have published on, and I hope that you pick and choose the parts that work best for you, and I'll share with you what I like most about them all. When I'm talking about emotional and behavioral problems in the context of autism, I'm defining that as significant impairments that occur because of emotional and behavioral issues over and above that child's baseline level of functioning, or that person's baseline level of functioning. Okay? So this is one key component of how I try to differentiate autism, or how I understand autism as it relates to additional mental health or associated mental health concerns, right? Understanding how Jake is doing on a day-to-day, or how Jake has been doing on a day-to-day, and then how that's changed for Jake is a key component to differentiating. Regardless, for example, social anxiety, right? If we're thinking about social anxiety, and a child's already always anxious about being in new social situations that are unstructured and unfamiliar because of a desire for sameness, because of difficulties interpreting social cues, if that's their normal, if that's their average, expected, then I'm not going to be saying, oh, this is in addition social anxiety disorder. If that's what I'm going to be thinking of is, let's make sure we can consistently provide Jake with the information that Jake needs so that he feels more comfortable, more ready in these environments. I'll be thinking in this antecedent way about ways of structuring the environments so that Jake can feel most supported, given his disability. But even there, Jake might have that kind of social anxiety, and we might bring in the social stories. And we might, make sure to review those with Jake. We might go on visits with Jake to new environments so that he becomes acclimated to those before task demands being added. We might do all of these positive behavioral supports, right? These antecedent strategies to support Jake and his autism. But even with that, Jake might have serious issues with anxiety which wasn't there before, to the point that he refuses to go in any environments that have peers, for example. And that might generalize to going to any environments with other people. So that same child who has anxiety and social anxiety for good reason might also develop social anxiety disorder in the sense that it's associated, it's above that child's own baseline. Okay? So the conditions that we're talking about, when we're thinking about how do we use CBT to address mental health issues in the context of autism, most often we're thinking about that additional piece. So that's one trick already, or one clue already, in terms of how do we differentiate or understand the relationship between the two. So you can ask yourself these kinds of questions when it comes to differentiating autism from mental health issues. The first would be, and this is from a publication recently by Kearns, are symptoms over and above what would be expected based on the child's developmental level and present challenges. So both are really important. Every child with autism, by definition of autism, will be struggling with often sociocommunicative or behavioral issues. What that looks like is going to be individual, right? No two kids are the same. But you have to take that and having a good understanding of what that typically looks like, as well as what the child's developmental level is. We can't have the same expectations of a child who's severely affected and has, who's strongly impacted by cognitive impairment, lacks language skills, lacks the ability for concrete operational thinking, for example. We can't have the same expectations both for treatment, kind of treatment, or for what it would mean to have anxiety, for example, than in somebody who has high cognitive ability, for example, is very verbally able, and is expected by themselves and by their environments to do other kinds of tasks. Okay? So you have to understand the person's developmental level as much as we can. Where are they at in terms of their thinking and their behavior? Publication just came out this month in the Journal of Autism and Developmental Disorders. Look, see what I'm doing? I'm going back to I promised you I was going to be a clinician, but I do evidence-based practice, so this is the best evidence. That just came out in JAD this month, right? That demonstrated that the degree of a person with autism's severity of anxiety issues and depression or mood internalizing issues is strongly associated not with their intellectual functioning, not with their adaptive behavior, their independent living skills, but the gap between their adaptive behavior and their degree of intellectual functioning. The greater the discrepancy between their cognitive ability and their adaptive ability, the greater their anxiety and mood issues. I thought that's fascinating, right? It's important to recognize when we think about developmental issues, developmental levels, it's not just about cognitive functioning. It's not just about IQ, right? In fact, IQ alone tells very little of the story. It's often IQ in concert with IQ, cognitive functioning as it interacts with, for example, social impairment or other kind of adaptive issues. Other studies earlier on have shown that which is the group in autism that will have the highest degree of social anxiety? It's those who have high IQ and high social impairment. Those with low IQ and high social impairment don't have the same degrees of social anxiety, right? Those with high IQ and low social impairment don't have the same high degrees of social anxiety. So it's about how do we understand these variables as they interact with each other. So you have to ask yourself, are there symptoms in this child that are over and above what we would expect based on their developmental level and based on their current challenges? Are those the symptoms that are associated with impairment? What kind of impairments are coming from those symptoms as opposed to the typical symptoms that person has, the symptoms of autism, right? How does it affect their social functioning in addition to the challenges they already have? Academic functioning, family life, the list goes on and on, okay? How might that be over and above the challenges they have with their developmental level? Can you distinguish those symptoms from the typical difficulties that child might have in general emotion regulation ability? Some people who are affected by autism are going to struggle, they always have and they always will, with regulating their emotions, right? That might lead them into challenges, but if we can build those skills, then they can maybe handle things regardless of the content areas. That doesn't mean we shouldn't treat emotion regulation or address emotion regulation, but we want to be careful of not seeing everything as an anxiety disorder per se. If there's a broader explanatory mechanism at play here, which might be, for example, deficits in emotion regulation, right? It might appear right now, the content might be a social anxiety disorder. But the actual process, the actual impairment that's happening could be transdiagnostic. Right? So you have to weigh the two options as you go to consider what's most. The same thing around sensory sensitivities. We want to make sure, and you'll see as we go through lots of the anxiety issues, how do we differentiate this from that? One of the major things that we're constantly going back to is how are sensory sensitivities factoring into this person's presentation? Well, in a clear way of helping to answer that is, of course, when those sensory stimuli are not there, are those symptoms still present? So are symptoms a step beyond what is characteristic of ASD? We've kind of described this already, but there is this kind of, and it's not clear, right, all the time. We're not always going to be able to answer this accurately. Right? But ask yourself the questions is what's really important. For example, many people with autism might be quite rule-bound. I need to, because of their insistence on sameness and their rigidities, might really have a particular way of doing things. That doesn't mean they need to have that anticipatory anxiety per se, that everything's going to go wrong in the future, right? That these things are always going to be violated. So what might be part of their autism, this rule-bound nature, might evolve into, and we'll see this as we go, into something more, right? Which can become generalized anxiety disorder with that anticipatory anxiety, or panic attacks, again, because of that anticipation, that is rule-bound. A rule-bound nature is a present state focus, right? A rule-bound nature is really a here and now focus. The anxiety that might manifest as a result of that, it becomes future orientation, becomes a future focus, right? So if we start to be able to differentiate this, we can realize, okay, with the rule-bound piece, we can put in these kinds of strategies. We can still help this person broaden their set of rules, shape that in a positive way. And we can also say, in addition to that, they are presenting with this high level of future-oriented thinking around violations to their rules, right? That might be something where we want to attempt some aspects of cognitive reframing, or changing self-statements about the future, or about their ability to handle the future, et cetera. So thinking, how do we differentiate these things, doesn't mean that one is treatable and one's not. It just helps us to isolate components to treat. So there are 4 key components, right, to any case conceptualization. One is accurately describe the symptoms and the problems as in the here and now. Bring the problems into the room. Right? What do the problems look like? It doesn't matter yet. You don't have to say these are problems of autism or these are problems of anxiety disorders, but what are the problems? What do they look like? What are those precipitating stressors that might be associated with the presentation of the problems? Not the causes of autism, but what are the actual precipitants to the thing you just brought into the room? That's the content, right? That's the narrative of what people are telling you. What are the predisposing events, the predisposing conditions that set the stage for struggles in general for this family, for this child, for this adult? Okay? Separate out as much as you can. Sometimes the same predisposing issues are also precipitants. But think about what are those potentially fixed factors in this person's life that are not as malleable to intervention? And what are the precipitating factors that are quite malleable to intervention, either through healing techniques or through exposure techniques or through changing the environment? For example, poverty might be a very relevant factor that predisposes some of the people that you support to developing mental health issues. It might not be the precipitant, and it might not be within your control or, as something that's quite malleable, something that can be changed. Of course, if we could raise everybody out of poverty, that would be huge, right? And maybe, I don't think there are any policymakers kind of in the audience here, but for the most part, when we're thinking clinically, we think about those as predisposing factors that are rather fixed, right? Same thing around the genetic contributions that somebody brings to the table. We often think of those. Those are very relevant predisposing factors that set the stage for presenting issues that are more fixed. So figure out this can help you answer that question. What are the low-hanging fruit? What can you readily address? That makes sense to address. But lastly, you can have all these things, and what we really need to also think about is what are the explanatory mechanisms at play? What brings this relevant information of the predisposing factors and the precipitants together in a story that makes sense to you, right? And in a way that you could pitch to somebody that you could share with a colleague in 3 minutes or less, right? If you end up having to take, I'm going to need a day to explain the then we need to refine what that explanatory mechanism is. Is this fair? Okay.